afternoon. I afraid you are not heard about clinical design and medicine. My division is included in clinical epidemiology, and I will show you what I'm doing now. First of all, we have classically three types of prevention method. One is primary, and secondary, and tertiary. And our preventive medicine department, we are introducing the prenatal or primary prevention. That means to avoid chemical damage to the infant before in the mother. So we are now studying about primary prevention, and also from 2003, quarterly prevention is advocated. That means how to reduce clinical or system damage to the human health. In other words, if we do not know about side effect of the drug, we will harm some people by ignorance of the side effects. And if our medical system is not good for acute patients, we will lose some savable lives in acute medicine. So we have to change the medical system according to the data analysis. And how to I want to show our study models. One is data analysis and variance analysis, and second is system analysis and procedure efficiency, and the third is system design. That means domestic medical service design. The first is variance analysis, and in Chiba University Hospital data, variance of prophylactic antibiotics and duration before surgery, duration after surgery, laboratory tests during hospitalization, imaging tests, and so on. We are using fishbone analysis of variance and clinical pathway flow analysis, and this is sample data of inpatient hospital stay length. So this is so 2 days, 4 days, 6 days, and this is a median, and we have to find these patients before day 8. So what is the problem? We analyze with fishbone chart. And the second procedure is procedure efficiency and liaison of medical service provider. This is stroke path. In stroke, we have 3 types of hospitals. Management hospital, that means an acute hospital, and after recovery, they will move to rehabilitation hospital, and the third is remission GPs, they are controlling the attack of the stroke. So before 2008, we have only this kind of flow, but we don't have so much talking about how to improve strokes path. So we have moderated, and there is physicians group work and nurses and so on. So we are holding a very big conference with these staffs once a year, and sub meetings we are having twice, one in 2 months. So we have 6 times a year. So we are very improving our stroke path or stroke treatment. And also we are now producing patient-centered network. That means patient himself can read medical record in their home, and also they can describe their health status or their anxiety or their questions about health. So physician can read it, what patients are doing in daily life. So we will producing this kind of patient-centered network, and we will release it next Friday, February. So the last is domestic medical service, and we are using medical demand projection. That means, I think you know, failure rate curve. That means some products will show failure, a high rate of failure soon after their production, but they will reduce, and after several years of using, the device will be broken, and some broken rate will be increased year by year. This kind of approach we are using how to project population or medical service trend analysis or medical demand projection, and we showed, you know, we have 8,040 hospitals in Japan, and our government says we will be 240 hospitals will be in the bankrupt in 2025, but from our projection, about 700 hospitals will be faced to bankrupt in 2025, and how to control hospital will be a very difficult problem we are facing. So we are talking with government and also local governments. And this is what we are doing now. Thank you.
Thank you very much, Dr. Fujita. Have a minute for discussion. Any other question and comment?
So, I'm not sure I followed the last slide, but what's interesting, you've got two trends. You have an aging population, which presumably is going to drive up demand, but you have a shift of care out of the inpatient setting, and presumably you're going to have a lower, reduced length of stay. So when you balance all of that out, you're ending up with a oversupply of hospital beds. Is that the idea?
Yes. Before this study, we also think about elderly people will have much diseases, and they have to be cared in the hospital. The hospitalization will be increased, and our government's projection will be true, we believe. But about 5 years ago, we estimate present status, and we thought in 2015, that is this year, we will be a lot of patients in Chiba Prefecture. But the truth was about 80% of beds are filled with patients. Our estimation was more than 90%, so there have some change for people's tendency to hospitalization. That is one thing is endoscopic surgery that reduced hospitalization very shorter, and some drugs like gastric ulcer reduced gastric perforation. So we have very rare to see gastric perforation today. So this operation itself reduced, and this kind of medical improvement will reduce hospitalization, and also our medical system is changing to European type or American type. The previous presenter said he wants to know how to shorten hospital stay in Thomas Jefferson. So this kind of approach is also evoking in Japan, and I think this kind of trend will be last next 10 years. So we will very severe condition in 2025, I think.
Maybe more a comment than a question. We're seeing the same thing in the United States, where we have the misfortune where 85% of our healthcare dollars are spent, or at least a high amount, in the hospital, even though most of medical care, 85%, is done outside the hospitals. And so we're really shifting to a more population health wellness model because we have to. We have to ensure high quality, value, patient safety, at the same time ensure patient experience. And maybe the question in here is, we're looking at engaging a wellness model, but also engaging patient in their care, perhaps even through technology, their smartphones, controlling diabetics, perhaps through technology, blood pressure, things like that. Is there a real movement in Japan to do the same, especially in response if there is such a shift?
Yes, almost same approaches now we are doing in Japan, but as for smoking, the situation is not so good in Japan, and because tobacco company has a very strong power, and is also as for another problem is from China. We have in winter time we have a very strong wind from China, and they will buy a lot of chemical products by air wind to Japan. So in the western part of Japan, they're suffering some health problem, but another area situation is improving, especially about walking. One of our colleagues is studying about walking and the health problem, and daily walking very much improve human health, also cognitive problem, and reduce dementia. He reported. So our approach is now some effect on human elderly health, I think.
So very interesting. Just clarification, I don't quite understand projection 1, projection 2, so if you could briefly explain that, I appreciate that. The second thing is, these inpatients bed maybe too many, so they have to be eliminated or switched to somewhere. So at the same time, government should spend some time in reducing outpatient number. I think it has been done by increasing self-payments, co-payments, by giving more medication. We only able to give 1 or 2 weeks in the past, but now maybe 1 month, 2 months, 3 months. United States, we can give a 1 year supply of medicine to non-patient come back for just hypertension. So do you see any kind of analysis or trend in outpatient patient management in Japan?
Yes. As for chronic disease management for outpatient is a very difficult situation. We analyze the tendency of outpatient, but the number of outpatient is changing year by year, increasing and decreasing, increasing and decreasing. This is affected by healthcare insurance system or another part I cannot recognize. Some are part of some are affected by a shortening of hospitalization, and I'm sorry, I still not distinguish the true reason of outpatient illness.
Projection 2 is not necessary to be 60% or less, but they have some tendency up and down around 60%.
This is only inpatients.
Yeah, no, what's the difference between projection 1 and projection 2?
One means our government projection.
As of today, less than
Yes,
60%.
they do not consider about the trend of medical improvement. They are using
One
the
day.
statistics on 2013, but we analyzed from 1995 to 2013, so we
Has
just
been
made
told.
this.
Very good.
Thank you very much, Dr. Fujita.